All right, we're going to start our third journal club and wait for some other fellowships to sign in. But we're going to start our first topic on regenerative medicine, and we're lucky to have Dr. Josh Martin speaking to us on the article "Clinical Efficacy of Intra-articular Mesenchymal Stromal Cells for the Treatment of Knee Osteoarthritis, a double-blinded, prospective, randomized, controlled clinical trial." Dr. Martin works with Dr. Malanga at the New Jersey Regenerative Institute, and after his presentation, we'll be interviewing Dr. Malanga on his thoughts on this article and in general on the topic of orthobiologics and their growing role in the area of sports medicine. With that in mind, we are going to turn it over to Josh to review this article.
Thank you. So this article, again, it's the clinical efficacy of intra-articular mesenchymal stromal cells for the treatment of knee osteoarthritis. So this is a double-blinded, prospective, randomized, controlled trial. And this article did appear in the American Journal of Sports Medicine with an impact factor of 6, which is pretty good. They did have an own disclosure that the study was sponsored and funded by the GID group, which did create the device, but with a lot of blinding, they mentioned in the study, they're hoping to eliminate any biases that could be related to this. So first, some background. Knee osteoarthritis is very common with high pain and disability burdens nationwide. The definitive treatment for knee OA is considered knee arthroplasty, but of course, such procedures can carry risks, should not be pursued too early, and the procedures themselves require intense rehabilitation. As physiatrists, we do provide some, and other sports medicine physicians in primary care and emergency medicine as well, we do provide some non-operative treatments that we're all familiar with for knee osteoarthritis, such as NSAIDs, physical therapy, steroid injections, and viscosupplementation, such as hyaluronic acid. But commonly, pain is refractory to these non-operative measures, and these measures are not thought to prevent cartilage loss. Thus, it would be helpful to add more options to our non-operative tool belt, including regenerative medicine, even if it may or may not prevent cartilage loss. So regenerative medicine has included the study of mesenchymal and adipose stem cells. These cells are derived from bone marrow or fat tissue and have demonstrated chondrocytic potential in vitro, the ability to create some cartilage. These stem cells are thought to differentiate, replace cells, and repair injured tissue. But unfortunately, isolation of only these particular lineages in sufficient numbers may require weeks of growth in a lab for cell expansion, which is difficult and labor intensive to do for clinical use. Harvesting and purifying stromal vascular fraction, or SVF cells, is a different kind of procedure that may be done at the bedside without the need for cell culture. This process is efficient, takes useful progenitor cells from adipose, and is not just the isolated mesenchymal or specific adipose-derived stem cells, which I will go into a little bit more shortly. For this procedure, liposuction is performed, fat is washed and filtered to obtain the desired cells, and then it's injected at the bedside. So these SVF cells collected that are then injected do contain a pretty heterogeneous concentration of a mix of nucleated stromal and vascular cells, as well as there's thought to be a mix of mesenchymal stem cells, monocytes, parasites, among some other support and signaling cells as well. Prior studies of SVF have generally supported injecting these cells for knee osteoarthritis, but a lot of the prior studies have been limited. These prior studies have often had small sample sizes, lack of control groups, and have also not been doing evaluation in conjunction with other modalities. Prior to the study, there had been some randomized controlled trials of mesenchymal stem cells and adipose-derived stem cells, but there had not yet been a randomized blinded multi-site trial to assess the efficacy of SVF injection as compared with intra-articular placebo injections. So such a study would be helpful to bridge this gap in the literature, which is where this study comes in. The primary aim of the study was to investigate safety and efficacy of SVF injection at 6 months compared to placebo. Efficacy was measured by the patient-reported WOMAC score, which is one of the most commonly used validated measures of knee and hip osteoarthritis symptoms that all of you in the audience are probably fairly familiar with. The secondary aim was to continue analysis to 1 year, and then also evaluate the impact on articular cartilage as by MRI evaluation. Of note, the MRI sequences were somewhat limited in this particular study. The authors did state that their hypothesis was, quote, patients receiving intra-articular SVF would show significantly greater improvement than patients receiving placebo injections, and this improvement would be dose dependent. Going into the methods, the authors set up this prospective, double-blinded, randomized, placebo-controlled trial across 3 centers. And also they had 3 arms. The arms included high-dose SVF, low-dose SVF, and placebo, which was lactated Ringer's solution. The authors included participants aged 40 to 75 with WOMAC pain subsection scores that were in a roughly mild, moderate to somewhat severe range. Patients recruited were with pain mostly in one leg and mild to moderate knee OA with the Kellgren-Lawrence grades 2 to 3 on X-ray. Additionally, these patients could not have had full thickness lesions greater than 1 centimeter on MRI. These patients must also have failed at least 2 non-operative therapies, which is reasonable considering we prefer to try the least invasive interventions before going to something like regenerative treatments. There was pretty numerous exclusion criteria, including BMI over 35, a high American Society of Anesthesiologists score, which would have reflected severe or incapacitating disease. They also excluded rheumatologic diseases, avascular necrosis, severe bony deformities, prior knee joint infections, and general contraindications to regenerative medicines, such as cancer treatments or bleeding disorders. The patients were randomized to equal numbers in each arm of the study, and there were opaque containers and syringes that were used for all injections to completely blind the physicians and the patients within the study. As per more detail about the intervention itself, the adipose was harvested from the abdomen in conjunction with a local anesthetic. The adipose was placed into the one-time use GID SVF2 processing device, which was used for harvesting, filtering, separating, and concentrating the autologous stromal vascular fraction cells. The injections were performed in the approach that a lot of us are fairly used to, which is that superior lateral approach under ultrasound guidance to ensure that the cells were getting into the joint. A sample of injection cells was also quality checked for colony forming analysis, phenotype analysis, and cytokine and growth factor assessment as well. So the WOMAC score, which typically ranges from 0 to 56, our primary outcome, was normalized on a scale going up to 100 for simpler percentage analysis. And an improvement of 33% or 33 points on this normalized scale is considered clinically significant. And so time points were taken at time 0, 6 weeks, 3 months, 6 months, and 1 year as well. And that's an example of some questions that are on the WOMAC. For the secondary outcome measures, the knee MRI was performed just before treatment at 6 months and at 1 year. Views were limited to just the sagittal plane, and the MRI was reviewed by a blinded fellowship-trained radiologist who looked for anatomic or cartilage changes in the AP dimension only. They did rate the cartilage on the outer bridge classification, which I did include below. For power analysis to make sure that enough patients were recruited, they determined that 11 patients per arm was necessary. And again, the 33% change in the baseline WOMAC was considered clinically meaningful. In terms of recruitment and patients they actually were able to get into the study, a ton of patients were initially screened for eligibility, 329, and 262 of those did not meet the screen. They were able to get a total of 39 patients to randomize, and they were able to get enough patients per arm for the study to meet what they wanted for their power analysis. Going into some of the patient characteristics, the patients were overwhelmingly Caucasian, but there was an even mix of genders, and there was a similar mild to moderate disease spread out through each group in all of the arms. Now, looking into the results, the median percentage change in WOMAC score for high dose, low dose, and placebo groups I highlighted can see was 84%, 52%, and 25% respectively. 3 patients in the high dose treatment group and 3 in the low dose treatment group experienced 100% reduction in WOMAC score, while no patients in the placebo group did. And so that, if you're comparing that to the 33 for the clinically significant difference, both high dose and low dose did meet that threshold, while placebo did not at the desired time point at 6 months. And the high dose and low dose groups also displayed statistical significance as compared to the placebo group, with p-values both below 0.05. This is a more graphical representation of some of the results I just went through. So all arms, including the placebo, did have a kind of a rapid benefit up to 3 months, yet the placebo subsequently wore off, while the effects of the high dose and low dose SVF injections remained over time and even were continuing to increase in benefit. Of note, that additional treatment line is a combination of both the high dose and low dose data points for a more average effect. For the MRI review at 6 months and 1 year, MRI noted no cyst formation, no heterotopic ossification, no neoplasms were noted at any of those time points. Also compared to placebo, they didn't notice any changes in cartilage thickness or any statistical differences in their Outerbird's classification, but they did note that the sequences from the MRI were limited. And then in terms of safety, there were no adverse events at 6 months and 1 year in any of the groups. So now going into a little bit more discussion, we did see a clinically and statistically significant improvement with the SVF injection in both low and high dose, with looks like a little bit of a dose-dependent response compared to placebo. And interestingly, treatment continued to improve after the 3 months and thereafter to 1 year. And a lot of the other injections that we commonly do, such as steroids or hyaluronic acid, do not seem to have this long-lasting effect when you compare it to what else is in the literature. So the authors did conclude that these injections are both safe and efficacious. For some strengths of the study, so this was the first randomized blinded multi-site trial to assess the efficacy of these injections compared to placebo. WOMAC is what I would consider the ideal validated measure for outcomes in knee osteoarthritis. This was multi-center. They did do quality control analysis as well. And the way that the procedure itself is performed is actually fairly amenable for patient visits. In terms of some limitations, so the patients and providers were unblinded after 6 months. So perhaps maybe some of the 1 year data may not be accurate without that blinding. As I mentioned at the beginning, there also could be some financial interest from funding by the GID group, but that group was not the ones that were performing the study itself. It was the Rothman Institute, and all the providers were blinded throughout the primary endpoint. Also, typically when you're trying to get more safety data, sometimes, especially in drug trials, we do try to get more and more patients and try to get some more time to see how things are working, which of course isn't something that we're able to do in a study of this size, and is more of something that we can get when we're doing longitudinal data in the population. There were maybe some limitations in terms of external validity, considering that the study was mostly Caucasians, excluded people that were hyper obese, and did exclude people with significant osteoarthritis in other joints throughout the body. They also didn't stratify outcomes by degree of osteoarthritis, which may have been difficult to do when you're only having roughly 13 patients per arm. And also the MRI scan sequences were, the focus was mostly on safety. So the resolution and that kind of stuff was not as great for their particular sequences. So it wasn't quite as good for assessing changes that you might associate for clinical efficacy if you're trying to really look at what's going on with the thickness of cartilage on a more minute level. And yeah, that's it.
I don't know if Rob's on mute.
Yeah, I think you're on mute.
But that was a great job, Josh.
Yes, excellent job. And this is a more detailed article. I chose it for a few different reasons. One, we want to use it as kind of a platform to understand different types of orthobiologics and to look at some of the potential treatment efficacies that we see with this sort of study. It's kind of where things are moving in terms of clinical care for regenerative medicine. And this was a nice study showing a nice efficacy of that. I wanted to bring up some questions that I had for that before we interview Dr. Malanga on there and get his experience with this, as he will be a research site for this product, and I think he'll be able to give us a lot more detail on some of the information on it and some of the day-to-day stuff as they become a site in the near future on that. So I had some quick questions I wanted to really bring out for the group to consider. One, the numbers in this study are pretty small, so that's important to consider. And we didn't see stratification by the types of arthritis, so we really don't know how this would compare to some other options out there, such as PRP or Visco. For example, we know that PRP in grade 2 arthritis will do fairly well on this. The question would be, how would it compare to this product there? Certainly with more severe arthritis, one would think that this product might offer much more benefit than that. So we really need to stratify by the severity of the arthritis and get larger numbers to really look at this. They really cherry picked a group that's pretty easy to get better with grade 2 to 3 arthritis without a lot of changes on MRI and other things. So they really selected out a group that should have a good response and should respond to other treatments. There's also the question on the dosing of cells, which is nice to see, but how they came up with that dose and whether that holds up, and is there a dose response curve? Does that maintain with larger study size or with severity of arthritis? We're not really sure. And then the mechanism of action here is always important to understand as we, as clinicians, try to understand what's going on and what other treatments might be coming down the pike on that. So with that in mind and those questions on my mind, I'm going to ask Dr. Malanga, who many of us we really know and is really a pioneer and leader in the field of regenerative medicine, to get his overall thoughts on the article. And then I'd like to ask him some specific questions about the field of regenerative medicine and how this article plays in. So Jerry, what are your thoughts on this article?
So, hi everyone. So I was fortunate to have been presented this data before it was published at a meeting. And quite frankly, I was way impressed with what was presented. So I'm not sure they quote unquote cherry picked their patient population. They picked a population that is kind of stuck in what is referred to as the osteoarthritis treatment gap, where they've exhausted all other options and now are faced with, the surgery. you rightly talk about stratifying treatment. So I fully agree with that. PRP is useful for grades 1 to 2 knee OA, and then kind of decays beyond that, and has a efficacy superior to placebo, corticosteroids, and hyaluronic acid, lasting on average 9 to 12 months. So when I counsel patients as to what is their best biologic intervention, we always talk about stratifying from the least invasive, least costly, and simplest to do. But if those three things are not coupled with best outcomes, that doesn't make it useful. So if PRP is relatively easy to use, although there are multiple flaws when we describe PRP, as many of you are aware of, right? So the studies even on PRP are totally flawed in many cases because they lack a dose description, quote unquote, as Rob was pointing out regarding this study. The lack of stratifying based on grades of arthritis. So they kind of focused on 2, 3s, which is really the sweet spot of biologics. And, if this is to hold up, it has to be way superior to simpler things, not much more costly, and should have a duration of effect much greater than what we're using right now.
So Jerry, we see these patients all the time. I mean, certainly on grade 2s, you see that Visco or PRP does very well on grade 2s on that. So would you say this response is stronger or just longer acting? Obviously on grade 3s, this is impressive because it drops off with the other 2.
Right. So I don't know about you, but HA works up to a point and then seems to fail.
Yes.
Even in grades 2, although there are that subset of group of patients that you keep injecting year after year and they do great. But I wouldn't say that's the majority of patients. PRP also is very helpful, but again, percentage-wise, and I'm not sure this has been overly well studied, what percentage of patients get this type of a robust response? I dare say probably not. And that's based on the literature, that's based on our clinical experience, that's based on our registry data experience. So again, there is a subset of patients who get PRP who do extraordinarily well. In fact, they get several years of benefit. There is another subset that get benefit and then get repeated injections. But again, I see a failure with dosing over time. So again, this study only, and most of our biologic studies carry out for 1 year, 2 years. Our registry and clinical experience show that these types of cellular procedures have a much more robust response and for a longer duration of efficacy.
Great. Let's talk a little bit about whether this does disease modification or the mechanism of action, or whether you think this is some sort of immune response and pain modulation, and what your thoughts are on that, whether it changes the course of the disease, or are we just doing some sort of immune modification? Obviously, we don't have the longer term studies, but just your overall thoughts on that.
Yeah. So by immune modification, do you mean changes in the cellular subtypes, such as the M1 to M2 macrophage subtypes?
Yes, I would just classify it as the overall inflammatory profile and changes of some of the subtypes. So you think we're seeing a change in that, or just a change in structural growth with some of these cells, or do you think it's all more of a modification of the inflammatory profile of the joint and those factors?
Yeah. So let's talk about the two ranges that people talk about when they talk about biologics. It's either an entire placebo effect and does basically hardly anything. And it's just based on the fact that a doctor says, hey, I'm going to give you this quote unquote stem cell treatment, and people believe in that and they get better. And then the holy grail is that we regrow articular cartilage and the cartilage is restored to its prior normal state. So I think those are the two wide ranges. And then what is the reality is often in between those two large extremes. So when we look at biologics in general, as to differentiate them from, let's say, corticosteroids, right, where corticosteroids provide a strong signal but alters the natural environment and has toxic effects to articular cartilage. The biologics are meant to normalize the articular cartilage environment and restore the homeostasis that has been lost, such that your cytokine profile and those cytokines that are derogatory, inflammatory, and pain-mediated that have increased in a degenerative joint become depressed, and the anabolic cytokines and factors improve and normalize to support the underlying articular cartilage. And then the question is whether you need quote unquote cells or not, and then whether you need quote unquote stem cells, and then what number of stem cells do you need, and whether those cells, our simplistic, now outdated view of those cells morphing into articular cartilage and filling in those potholes has now come and gone. And we now understand through the work of Arnold Kaplan and others that those cells go to that area and release signals and read the environment and then provide signals to the local environment to change what is occurring, such that the underlying articular chondrocytes stabilize, and perhaps there's a multiplication and improvement by those cells locally that provide an improved joint environment that a patient feels in terms of less pain and capabilities of functioning. And in many prior studies, improvement, when you look at it by MRI and or second look arthroscopy, the articular cartilage looks better, both on imaging and on arthroscopic evaluation.
Good. So I wanted to ask you what you think. There's different, obviously, categories of orthobiologics. Obviously, people are doing from the PRP, the BMAC, to the MFAT, and now FAT with SVF. Here, do you see a big difference between those, and how do you think this would compare to straight MFAT with the different systems out there, or BMAC? And what would be your thoughts on that? Obviously, this adds another layer of processing,
Right.
and currently is obviously beyond minimal manipulation, which we're allowed to do. But how do you see that playing out if you had a crystal ball?
If I had a crystal ball, I'd be able to tell you what the weather is tomorrow, but I don't. But here's what I've observed so far. Prior to 2015, the cellular procedure of choice was bone marrow. The literature to support bone marrow cellular procedures was pretty reasonable and very large compared to what is available for adipose tissue. Since 2015, the literature to support adipose tissue as a method of supporting and treating orthopedic conditions has vastly increased. And now when you look at adipose versus bone marrow, there are probably more positives for adipose over bone marrow, although in select populations, I still think bone marrow might be the better choice. However, it wasn't until about 2015 that there was a FDA compliant method of harvesting adipose. Now, you can harvest adipose before this, but processing of adipose, right, raw adipose is not very useful, other than perhaps as a scaffold, because raw adipose has many undesirable constituents that are probably inflammatory in their nature. There's connective tissue, there are oils. If you can, so MFAT came out where you can, with minimal manipulation and with what appears to be FDA compliance, wash the fat, cleanse all the undesirables, microfragment it, inject it. And we've been involved with that process since 2015. We were probably the first group in the United States to do it. And it's been very rewarding. So then the question is there something better? And in other countries, SVF literature has been published with pretty amazing outcomes that look at not only pain and outcomes, patient outcomes, but also MRI and second look arthroscopies. But in the United States, SVF is considered a drug, and perhaps rightly so, because it does require enzymatic digestion, and it does potentially expose, if you're not careful, that product or that final entity to bacteria if you're not careful. So if you can get an FDA compliant device, and if we can figure out what is the right range of dosing, I think that's going to be the future.
Good. That's great to hear on that. A quick question on the dosing here. This is one of the few studies that really looked specifically at dosing on that, and we see that we see one or two articles with WOMAC on cells and versus very few on the MFAT dosing. What are your thoughts on the dosing here, and more the cells that they're delivering there? You think it's a dosing response that we're going to see in the more severe, or do you think how that plays out a bit? It's very interesting to be able to have a prescription with the right amount of dosing, but there's so many variables by person. I mean, it's really going to be hard to tell, I think, on this. What are your thoughts on that?
Well, my thoughts are that in almost all areas of medicine and in most areas of life, figuring out the right amount is key. And that's been maybe the flaw of using MFAT, is that we have no idea of our dose. It's worked out, but I think we do need, and the entire area of biologics is hamstrung by this immaturity and this lack of progression to more specific measuring and figuring out the right dose. So I think ultimately what we will find is that there is a minimal dose. So you need to get at least this number of cells for various grades of arthritis. And so that minimum dose might be different based upon age, perhaps sex, perhaps BMI, but certainly based upon the severity of the disorder. And then there's probably going to be a maximum dose. So many of the biologics, when you scrutinize them, will show that actually more is not always better, and you can overdo it. And so you may not want to go past a certain dose. So just like the Goldilocks principle, you don't want to have too much, you don't want to have too little. You want to have the just right amount. That might be a range, and that range might disorder type or degree.
I see. Jerry, do you think this product, it's obviously going through further studies and stuff, do you see things moving to more the SVF route with this product getting FDA approval and eventually insurance approval, or do you see other things on the horizon that obviously there's a bunch of other products that are in research on arthritis that might come in and be effective? How do you see that on that? You see this is where things are going to move to with SVF?
Yeah, I definitely do. I think this group is probably ahead in in their clinical trials and studies, and they need to finish and produce the data. But if the data holds up the way this article demonstrates, I think it would be hard for the FDA not to approve this device for knee osteoarthritis, and thus this company will have the first device that's FDA approved for a specific condition. I think others are seeking that same type of FDA approval. And then we may have a variety of different devices ranging from MFAT, which is maybe a little bit easier to do, to more specific SVF devices.
Mhm. And can you speak to what your thoughts are on this? Obviously, we know through studies that knee osteoarthritis is probably the best joint we deal with in terms of OA and our regenerative approaches, and some of the other joints just don't do very well. Do you see this carrying out across the board, for example, in hip OA, in early stages, or shoulder OA, and do you
Yeah.
see it crossing over to that, or do you have any experience with that with SVF, or just overall your experiences with biologics in different joints?
Yeah. So great question. Shoulders in our registry and other people's data, and even in our MFAT data, do extraordinarily well also. So rotator cuff tendinopathy with degenerative arthritis do very well. Ankle joints do very well. And they've also done historically well with bone marrow also. It's the hip joint that becomes the most difficult area to try to figure out optimal treatment. The hip joint lags behind compared to the other joints. Even the CMC joint of the thumb does actually reasonably well with PRP, and does quite well with bone marrow, and can do quite well with various adipocellular procedures. So the hip and then the spine become the perhaps more difficult hurdles for the future.
Great. So we have about 5 more minutes here. If you have questions, please put them through on the chat for us, and I'll try to get them out through that way. So I think in summary, this is a very, very promising article. Obviously, more work needs to be done with larger study sizes and stratification, but we're looking at this as a very promising treatment for osteoarthritis that's in the early grade 2 to 3 stage that looks promising. Now, a lot of people are doing work with SVF across the whole body. Some people even doing intravenous SVF, and I have some colleagues of mine that do intra-articular with intravenous. Do you see some sort of systemic role with this, or is it all localized to the joint? Because obviously SVF is being used throughout through different things. Any just overall thoughts on that?
Well, I have concerns about people that just throw SVF or other biologics in any potential site they can stick it in. So just without being a little bit more thoughtful and without supportive data. So I do have a sense that we need to treat diseases holistically, such that we need to look at the milieu of the entire person and not just the quote unquote arthritic knee joint, right? That arthritic knee joint likely lives in a milieu of a person that may have some other systemic issues that are driving that. And we now know that many chronic diseases are driven by what is referred to as systemic inflammation. And systemic inflammation is driven by lifestyle issues within the average American and perhaps average person living today. So that's associated with obesity, with stress, with vitamin D and other deficiencies, dietary things, lack of sleep. So trying to come up with a pill or an IV infusion to treat things that should be treated more holistically, I think is a bit flawed. I do think in certain people who are trying to do their best and can't get through, looking at methods of addressing both the distal organ and other methods of modulating systemic inflammation might be useful. I mean, our current COVID situation and pandemic looks to be just a specific virus that's attacking a specific area of the body, the lungs or the vasculature. But in fact, it also is almost universally affecting people with all these systemic inflammatory processes.
That's a great point to bring about. I want to emphasize, obviously, to everyone, this obviously is a research device and that it's not approved for anything beyond research, and you're not allowed to do any SVF products in the US without a strict protocol from the FDA, and certainly I don't encourage anyone to do any of these products. But Dr. Malanga is going to be part of this research, and I think we'll be sending some patients his way, and look very interested in following up to see and learn more about this and get some further answers on cases of OA and how this may be a role and where it fits in the whole treatment paradigm. Clearly, there's a subset of patients with moderate arthritis that are not either quite too young or other factors to get a total joint, and we need better treatments for those patients in that sweet spot of younger with OA to really get treatments, and this really fits that gap based off of these studies, and we look forward to that further research. Jerry, any further concluding thoughts on anything? We have a lot of fellows here, so give us some words of wisdom on some just in the last minute or so on where you see things going, or other thoughts on this study and through your vast experience with regenerative medicine, and obviously changed throughout the years. So just some concluding words on things would be very useful.
Well, first, Rob, I want to thank you for putting this together and for inviting me to do it, and thank everybody that's on. My closing thoughts would be this: when we approach any patient,
Can you
strength
go back,
training.
Jerry? We got cut off a little bit, so I'm sorry. We lost about,
I'm sorry.
We lost about 10 seconds. So just go ahead, take your time.
I was talking about treating the patient holistically and looking at all the different treatment options, and not going straight to biologics. If you're going to use biologics, think about the science, think about the physiology, think about the mechanism of action. Again, start with the simplest, least invasive method that can provide effect, and then ultimately collect data, right? And as you know, I've started a database company, but that is because data will help drive what we do and should help what we do in medicine in general. So collect data, let's look at the outcomes, and let the outcome and the data drive what we do in the future.
Well, excellent. I mean, thanks so much for joining us and providing your wisdom and extensive experience, and congratulations on being one of the research sites for this very, very interesting device that's coming out there, and very interesting in that. I think it's really going to look forward to seeing that data and going from there. Thanks everyone there. We're going to conclude here. Just a few things. Next week we'll be returning to sports ultrasound. I will try to get the article out by Monday on that, and we'll be combining that with a demo, and then we're going to be alternating weeks between regenerative topics and sports ultrasound. Our next regenerative topic will be talking a bit about shockwave modulation of tendons and how that works as a regenerative type of treatment on that. If you have ideas, thoughts, improvements for our format, please reach out to me and let me know. I will be updating the email list to get everyone on here that I've missed a few people. So we'll do that. And once we get it down, we'll be expanding it out to others, but we're going to keep it closed until we work out a few more kinks. But thank you again for joining us, and have a good day and a good holiday weekend.
Thanks, Ron.
Bye-bye.